It's my great pleasure to be here to present our recent study about regenerative medicine for spinal cord injury using iPS cells. Here is my COI disclosures. Okay, let me begin my talk with this slide. This is Lamont Cahar. He's a big star in the field of neuroanatomy at the 20th century. He said, spinal cord injuries result in devastating of function because spinal cord of human beings never regenerate after injury. This is what is called Cahar's dogma. People believe in the dogma for a long time. In fact, this is my patient. He was 18 years old football player. During the game, he suffered from complete tetraplegia due to fracture dislocation at C5-6 level. In order to decompress the contured spinal cord and reconstruct the spinal column, we performed anterior spinal fusion with braiding and posterior wiring at that time. However, even after the surgery, his tetraplegia never recovered, as you can see on these MR images. His spinal cord was completely ruptured. Can you imagine how devastating his situation is? All he can do is just moving his shoulder like this way. That's it. No other movement. His life was completely changed at that moment. This is a reality we are facing in clinic. To realize regenerative medicine for spinal cord injury using iPS cells, we have been working on the preclinical studies for these 20 years. In my today's talk, I have two topics. First is subacute spinal cord injury. Previously, we reported iPS NSC transplantation promoted functional recovery in both mice and common marmosets. This is a non-human primate spinal cord injury models. But it's kind of hard for you to understand how different their performance are. So let me show you the movies of the representative animals in each group. This is control animals. Because we induce severe contusion injury at C5 level, they suffered severe tetraplegia. They could not move forward by themselves, no matter how hard we push them to move, at 12 weeks after the injury. And next is back grip test. They could grasp a pen perpendicular to their body plane at the eye level, but they could not grasp a pen parallel to their body plane because their forearms were not pronated enough. And they could not reach the pen 3 centimeters above their head because they could not elevate their shoulders. It's close, but they couldn't make it. The last is cage climbing test. We put the marmoset upside down at the side wall of the cage. Due to severe tetraplegia, they could not keep their body by themselves. Okay, try it again. They couldn't make it. They're almost falling down. This is a control animal, 12 weeks after the injury. On the other hand, this is the transplanted animals. You can see a difference. They could walk around, just blink, and walk again. And a back lip test, they could grasp the pen very quickly, even though they show the spasticity of their fingers. And also, they could grasp the pen 3 centimeters above their head because they could elevate their shoulders. And they could keep their body by themselves, change the direction, and climb up the cage. You can see a difference. These are the potential mechanisms of function recovery after iPS NSC transplantation. First, synapse formation by graft-derived neurons. Second, remyelination by graft-derived oligodendrocytes. The third is trophic support. Actually, iPS NSC secretes several growth factors such as BDNF, NT3, etc. And this is a roadmap to clinical trial of iPS NSC transplantation. Clinical grade iPS cells were established at Kyoto University by Dr. Yamanaka through the in vitro aberrations of iPS cells, they select a good clone of iPS cells and send them to us. We induce their neural differentiation through the in vitro as well as in vivo aberrations of iPS NSCs. We selected the best clone of iPS cell for clinical trial. Before starting clinical trial, our proposal had been deliberated by Japanese Scientific Council of Japanese government for a long time, and which was approved on February 18th, 2019. Okay, here is the outline of our phase 1/2 clinical trial. This is interventional open-label clinical trial, and we recruit 4 patients with AGA grade A. It means complete spinal cord injury after 2 to 4 weeks after injury, whose age is over 18 years old. And we performed iPS NSC transplantation into the regional epicenter through the intra-regional injection, about 2 million cells. And the primary outcome measures are types and frequencies of adverse events and serious adverse events, and increase of AGA motor scores from the baseline at 6 and 12 months after transplantation. Actually, we are ready to start this clinical trial at the end of 2019. However, as you know, due to the pandemic of COVID-19, our clinical trial was suspended for about 2 years. But eventually, we could perform a transplantation of iPS NSC for subacute CI as a first in-human trial in December 2021. These are preoperative MR images of this patient. As you can see, his spinal cord was almost completely ruptured. Let me show you the movie. Through a conventional posterior approach, we perform rhabnectomy and open the dramator under the microscope, and we do transplantation of iPS NSC, transplantation through an intra-regional injection. And to date, we performed iPS NSC transplantation in 4 cases, and ongoing observations were being continued according to our protocol. All I can say right now is that we obtained a positive result, but before fixing all of 4 patient data, I can't say anything in detail right now. But maybe next year, I will be able to make another presentation in detail. This is a story about subacute CI. Okay, let me move on to the second topic, which is chronic CI. Theoretically, to regenerate the injured spinal cord, transplantation of spinal cord type of iPS NSC is ideal. But we couldn't do that because we did not have any differentiation protocol of iPS into spinal cord type of neural stem cells. But recently, we developed this protocol. And you can see here, they're totally different gene expression profile between the hindbrain type and the spinal cord type of iPS NSC. And next, we induce the severe contusion injury at the thoracic level in immunodeficient rat, and we found that there severe atrophy of the spinal cord and cystic cavity formation. This is the control animal. But at 6 weeks after the injury, this is a chronic phase, we perform a transplantation of spinal cord type of iPS NSC, and you can see a difference. Spinal cord looks totally different between control and transplanted animals. Almost no atrophy of the spinal cord. The green dots here indicate grafted cells, suggesting graft cells could well survive and migrate into the host spinal cord. Here, this is a regional epicenter. Surprisingly, spinal cord were almost completely replaced by the graft cells. They could differentiate into neurons, such as motor neurons and interneurons, as well as oligodendrocytes. And we performed immunostaining for phosphorylated GAP43, which is a marker for regenerating axons. And you can see here, the number of rephosphorated gap43 fibers, even in a chronically injured spinal cord. From the viewpoint of clinical setting, we confirm these findings by new MR imaging technique, which is diffusion tensor tractography. These are pre-injury images. You can see there are a number of depicted fibers within the spinal cord. This is a normal spinal cord. After injury, 6 weeks, you can see the number of depicted fibers is significantly decreased along the region site. But after 12 weeks, the transplantation, you can see here, the number of depicted fibers predominantly increased. These are same rats, time-dependent change. We can see it by MR new imaging technique. And eventually, we perform behavioral analysis. This is a control rat. Due to the severe paraplegia, they could not bear their weight on their hind limbs. But the transplanted animal watched their hind limbs. They could bear their weight on their hind limb. Quantitative analysis by BBB motor scoring scale, there are significant differences in this motor scoring scores between these two groups. Based on these findings, we have already fixed manufacturing protocols in collaboration with pharmaceutical companies. Right now, we are working on the inclusion and exclusion criteria of the patients and rehabilitation protocol before and after the transplantation. And we are planning to start this clinical trial for chronic SCI patients in 2016. Okay, I'd like to express my sincere gratitude to all my colleagues, especially Professor Okano and Professor Yamanaka. Thank you for your attention.
Thank you, Professor Nakamura, for this inspirational talk.
Thank you.
If you want, we will open the floor for questions. So, Anwar.
Thank you for this great talk. It gives us some hope. I just want to know regarding the subacute cases, the 4 persons that you injected, how long after the injury was that?
Okay.
And what are the results so far? Okay. We didn't get any outcome.
Okay, definition of subacute phase is in human between 2 and 4 weeks after injury. That's the subacute phase. And that's why we transplanted iPS NSG between the 2 and 4 weeks after the injury. And it's hard to say in detail for the patient, but okay, descriptive, okay.
So the first one
3 out of 4 patients, they showed a function recovery. Oh, is that okay? So, I never said about this, but 3 patients showed a function recovery. Now 1 patient can walk.
Wow, okay.
Excellent.
That's it. No comment.
Off the record.
Okay. That's great.
Hello, Victor Aleinik of Kazakhstan. So, as we know, the main problem of spinal cord regeneration after trauma is the scar formation due to astrocyte trauma. How do you solve this problem?
Okay, that's why we transplant subacute phase. Before establishing that glial scar formation, it's getting harder and harder to regenerate. That's why between 2 and 4 weeks, there's still possibility to regenerate through the scar and the glial tissues. So that's why we transplant the subacute phase. In chronic phase, complete chronic phase, we have to do additional treatment, such as conditionase ABC or the semaphore 3 inhibitors, or we have to combine the treatment to overcome the glial scar formation. That's clear?
Thank you.
Jan Philippe.
Yeah, thank you very much, Professor Nakamura, for being here with us and for presenting this very high-level work.
Thank you.
Just for the clinical insight, I know it's just preliminary, but what are your thoughts? Is there a limitation in terms of Asia scale where you would inject, and also in terms of levels? Because we know that the vascularity, for instance, in the thoracic spine is not the same as in the cervical or ticonus.
It's a very good question. And we have to think about the injury levels. The cervical and thoracic, it's a very different situation. So, well, But in our model, common marmoset model, we induce a cervical contusion injury model, and they showed functional recovery. So maybe C3, above the C3, it's kind of hard to perform transplantation of BSNHC because of respiratory damage. So, but below the C3, 4 level, we can do that. So, and also thoracic level, of course, we can do that. So, is that answer for your question?
Yeah, and would you also do it in a patient who is Asia A, for example, complete?
Yes. Actually, in subacute clinical trial, all the patients are Asia A. Okay? No B, no C. That's why we have to show the clear evidence, the efficacy of the iPS NHC transplantation. That's why we just recruit Asia A patient only in this clinical trial. B or she as a, it's recovered spontaneously. That's why we just recruited Asia A patients. Is okay? Okay, thank you.
So, Professor Nakamura, for the time being, you're doing it through an open surgery.
When time?
No. For the time being, you're doing it with an open surgery. No?
Right.
Is there a place to do it with some image guidance, without opening and maybe repeating the shot?
Actually, there are a lot of vascular on the surface of the spinal cord, and we have to check if there is a vascular. So otherwise, we can damage the vessels on the surface of the spinal cord. So we have to open it and directly see where is the vascular and where is the posterior surface. So after I identify these things, I have to inject into the injured spinal cord by my hands. So open surgery is much better than the closed surgery.
Thank you.
Does it make sense?
It does.
Okay.
So, if there are no further questions, we would like to conclude this session. Thank you everyone for being here today with us. And thank you again, Professor Nakamura, for making it.
Thank you so much.
Thank you.
Thank you.
Thank you so much. This was really
Appreciate
good.
it.